Thank you, Richard. Our next speaker is Holly Donaldson from the Australasian College of Emergency Medicine.
Thank you, Jennifer. Thank you everyone for the invitation to speak today. It's really wonderful to be able to think about the next generation of CPD because it is indeed a bit of a broadening scope from CME and beyond.
Oh,
sure.
You've got a gentle voice.
Okay. I've been told to go closer, so I will do that. Okay, so the context for today is I want to give a bit of context because, of course, every specialty is a bit different and therefore the CPD activities are going to be different as well. The components that I wanted to pull out, because we have done a significant reassessment and revision of our CPD program, include the audit process, our approach to the audit of medical practice, and also the procedural skills renewal, which is part of the revised CPD program being implemented in July 1st of this year. And of course, the overarching question is, so what does all this mean? And to what extent does ACEM CPD actually... Oh, okay, so we're going on to content. This is a bit touchy, this thing. All right, so emergency medicine is quite a new specialty, as you may know. We were formed in 1984 with 73 founding fellows, and then we've grown to over 1,600 fellows and 2,500 trainees. And one of the good things is that we actually have a really high compliance rate. It's consistently over 95% and is currently over 99%, which is pretty impressive. And one of the reasons for this is because we do have an online CPD platform, and this is currently being redeveloped because, of course, it needs to reflect our new program. But also we have a really robust and active CPD committee. So we have regional representatives which follow up with fellows who have been audited and also if they are non-compliant. And this really helps to assist them, and we take a very much a supportive rather than a punitive approach to all ACEM processes. So I was thinking about the various ways that I could, introduce the three components that I wanted to talk to today. Oh, this is it. The timing's not quite right on this, but that's all right. What's going on here? Okay, I wanted to introduce, this is actually a really quick animation. Animation is one of the things that we're introducing in a whole range of our online learning portfolios. And so I thought I'll pull this out, and it actually sort of pulls together some of the key learning, and then I'll delve into those in greater extent. Good to go now. Cute, isn't it? It's a good way to sort of just highlight some of the things that we're doing at ACEM. So the first thing I wanted to delve into a little bit more is our audit. So we have, as the animation showed, we have increased to 10% going forward from July 1st of this year. Don't do that? Okay, I've got it now. All right, so some of our secrets to success actually include around that it's primarily a desk audit. So previously, actually, all of our CPD fellows were, our committee fellows were doing these. But now what we do is a desk audit, and then we get a checking process through the regional representatives. Also that we only have 1 year, so it is reasonably simple to do. However, it's robust because we look at all the categories. I know that some of the colleges only look at certain components. But this allows us to see that everything you're doing is, yes, we can validate that. And the other thing is that clear documentation is really important, as you may know. So if you are selected for audit, we give the lovely procedure, which who doesn't love reading those, as well as the provision of audit documentation, and of course a form to marry those two together. And again, we always like to have a supportive approach, so if anyone is struggling to get their documentation together, we'll always try and help them with that. Backwards? Yeah, okay. All right, so this is just a bit of a flow diagram. I'm not going to go into too much detail about this, but essentially I just wanted to pick up on some of the process. At ACEM, we run in the financial year, so it goes from July to June, and that means we select our auditees in January, and they have about 3 months to put all their documentation together and send in to us. I just wanted to highlight a couple of things on this chart. The first being that you are ineligible if you've already been audited in the current cycle. Also, if you're under exemption from CPD, but if you're non-compliant, you will still be chosen. So this maintains we get everyone that we need to. Of course, after notification, participants will then send in everything to us and do that desk audit. And again, the CPD committee will do a personal follow-up for fellows in their region who have failed to submit in a timely manner. So that gets them going. And last but not least, we'll go down, obviously they send in the audit and we notify them and it's all successful. At no stage have we had a fellow actually failing an audit, but we have a very clear policy in terms of what will happen if you do fail. And this is around being non-compliant for that CPD year and also not being able to have a letter of good standing. And so for the remaining time, that obviously still applies, but also you won't have a cycle compliance. I'm very pleased that we have not had that, and I hope we don't get any of that in the future. Okay, so moving on to the audit of medical practice. As you may know, the audit of medical practice is a new requirement for New Zealanders. And so we have introduced this into our CPD program, but had a really thoughtful and I suppose proactive approach to figuring out what an audit of medical practice, or AMP, will look like in our context. So what we did, the CPD staff worked with the CPD committee to create a really robust implementation plan. And this plan outlined a whole raft of example AMPs, which is relevant in the emergency medicine specialty in these 5 areas. So clinical quality, and that's probably the most obvious in this regard. Then, of course, documentation and communication. Patient flow, so this is the really sort of interesting one. It's the did not waits, which happens a lot in emergency medicine. Patient satisfaction and a whole raft of other things, for example, the 4-hour rule. The next one is workforce. So staff satisfaction. Burnout is something I'm particularly interested in, and also leave and retention rates. And last but not least is education. And we were very happy that workplace-based assessments and even mentoring programs and grand rounds evaluations were considered by the Medical Council of New Zealand to be perhaps the best of these, as a really great way to see if education is indeed improving practice. So I'll just give you a minute to have a quick look at this. It's just an example of one of the departmental clinical quality audits. We have actually allowed fellows and other CPD participants in New Zealand to have either individual, departmental or hospital audits if they can demonstrate their role in it and also how to improve their practice. So I'll move on to the new CPD program, and in particular the procedural skills renewal, because this is of course the core component of emergency medicine. So recognising that a CPD activity type is only one of the factors which really brings out the quality and I suppose enhances the skills and knowledge of the specialty. We actually moved away from a weighted point system and towards a purely hour-based system. So from July 1st, we'll be needing at least 50 points per year and 150 in a 3-year cycle. The 4 categories in the CPD activities are self-directed learning, group learning, teaching, research and educational development, and quality enhancement. So the reason why there's asterisks next to quality enhancement is because we consider this to be a vital part of CPD, and it actually has cycle requirements. So fellows and other CPD participants are required to spend at least 30 hours in each of these areas. And as you can imagine, the audit of medical practice does give New Zealanders a bit of a head start in this requirement. And of course, procedures, last but not least. And this is around both annual and cycle requirements, which I'll cover on the next slide. Okay, so I have to say I've worked in a couple of medical colleges, and the CPD programs are usually very complicated. So we were trying to make it very easy for our fellows to understand. And what is easy to understand than ABCs? So airway, breathing and circulation are considered to be core, which means that they need to be completed once of each every year, and then also once by performance in a 3-year cycle. And the reason why I'm saying by performance is because we're recognising that fellows have a broad scope of practice and also teach and supervise. So this is why they need to actually perform once, but they can do other mechanisms as well. And of course, our scope of practice. Again, there's a big diversity in this specialty amongst every other, and we have revised and expanded our scope of practice skill set, which includes about 85 procedures, and at least 10 of these need to be performed, taught or supervised in the cycle. So this is a bit of a busy slide, I know, but the reason why I'm highlighting it is because it is an example of the procedural skills list from the draft ACEM training program curriculum. So this is going live in the 2015 training program year, and I wanted to highlight the continuum learning approach that we have done when revising the CPD procedural skills list. So going from left to right, we can see the group, which is obviously circulation and then the individual procedure. If it's considered common and important in emergency medicine, and then of course the 4 stages of training, and at what sort of mastery level the trainees are expected to perform at each of those stages. So taking an example is in the circulation, there is emergency pericardiocentesis, yes, got it right, and it's not considered to be common in emergency medicine, but it is important. And so as you can see, there's actually, we don't get a 5 by the end of training, and this actually provides a really nice mechanism for fellows to actually continue to become 4 proficient and 5 expert in their CPD. Okay, so that's nice. You're probably thinking, what does all this mean? So we're going to just have a bit of a look at to what extent does this new ACEM CPD program equal revalidation. Well, it's always nice to have a framework to compare. So I did pull out the GMP guide to revalidation and the top level descriptors. So I thought traffic light system makes it easier. So continuing professional development, I hope that you would agree that our CPD program looks fairly comprehensive. We also have a very high compliance rate and a robust auditing process. So that would get a bit of a green, I think. And similarly, we have a really a nice and comprehensive quality improvement category, which is mandatory. So that's a green as well. There we go. However, significant events are not currently within the purview of ACEM. However, we definitely recognise this is an important component and does need to be recorded. We do have an audit of, a underperforming fellows procedure, and this does include a personal learning plan or needs assessment to help re-entry to practice. So we're not doing so well there. Feedback from colleagues. Obviously this is very important, but something perhaps we're only partially complying with because of the peer review and also the audit of medical practice. One of the things for both the feedback from patients and colleagues, of course, would be the multi-source feedback. That's the orange, going into patients. Multi-source feedback, as we've spoken about a lot today, would be really valuable. And unfortunately, because of a variety of reasons, it's really logistically tricky to implement in the emergency medicine context. There's a high throughput of patients, and also it's quite difficult to then get patients to give physicians feedback. So we are really considering the best way to do that in a sustainable way, and then implement it in our training program and then beyond to the CPD. And complaints and compliments. I would say this is a no, this is not something that we do, but again, the reflective element of this would be really valuable. And so we'll certainly keep our eyes out on it to consider if this is something which ACEM can do in the long term. And I think overall, what we need to really think about is, does the CPD requirements, the challenging thing is, really critically thinking about the CPD requirements and if this really equals authentic practice improvement. So I'd like to leave you with that thought today.